Salam alaikum. Dear colleagues and friends, it's a great honor to speak here today and addressing some aspects about non-religious fasting in health. I am Peter Schwarz. I'm president-elect of the International Diabetes Federation, and I'm coming from Germany and have a chair for prevention and care of diabetes. And I must say, over the last years, we got extremely excited about the potential of fasting for prevention of diabetes and to improve diabetes care. And for the next 15 minutes, I would like to go through with you through this. I already have mentioned Peter Schwarz. I am Chair for Prevention and Care of Diabetes, current President-elect of the International Diabetes Federation, and will become President of IDF in April 25. And I'm member of the NCD Alliance Board. And in the combination of this function, our aim is, and also my passion is, to do whatever we can do to improve quality of care for people with diabetes worldwide. And I think in the future, fasting will become a very strong activity in improving diabetes care. But for me, prevention, 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 this is where my heart is beating from. And these two numbers are, for me, the best strategies or the best highlights for prevention of diabetes. Walking 10,000 steps a day prevents nearly any chronic disease, and walking only 1,000 steps more than you normally walk. It doesn't matter how much you are walking per day. 1,000 steps more at 600 meters as a diabetes patient lowers the postprandial blood sugar by 1.5 millimole. This is cool strategy for prevention of diabetes. But we in Germany, we are lazy. We are not walking anymore. We walk 2,700 steps a day. Everything below 5,000 is seen as being inactive. And if I ask the other way around, how many hours per day we are inactive, this is the answer. We need only 20 minutes to achieve 2,700 steps. This is what we have to change. If we are honest, true diabetology is not in our brain as diabetologists. It's not in our prescription. It's in the muscle of our patients if we would be able to activate them. And if we would be able to activate our own muscle, and we are also the same as lazy as often our patient. But let's go deeper into it. We are physicians, we are scientists, we want to understand the pathophysiology and find the answers for the best effective treatment in the pathophysiology of diabetes development. What you see here is healthy. This is a young woman, high normal A1C, being or eating a lot of carbs every day. Every green arrow is means eating carbs. And the purple line is glucose done with CGM, and we see nothing. There is no elevation of glucose seen in this woman. She is very insulin sensitive, so she's very healthy. The opposite, her father, and the father is actually having a better A1C than the daughter. And we see in the morning, he's also having normal glucose value, and then fluctuations are starting. And this up and down of glucose, we could say this would be breakfast and maybe lunch, then it's going down here. There was no treatment, there was no physical activity. But today we know this up and down of glucose, this is driving morbidity and mortality for our patients. So the logical consequence is, because we don't find these people, we should think about the pathophysiology and think about applying interventions who at the end do this. Cut high normal or cut high glucose values and cut low glucose value into a near normal range. And by this being of benefit to our patient. We can imagine if you have two patients with an A1C of 7, one is having mild fluctuation, the other one has big fluctuations of glucose. The one with the big fluctuation gets a stroke and a heart attack. The one with a mild fluctuation may not even need a good treatment. So normalizing the shape of glucose is probably in the future an effective goal for diabetes management. And I'm very sure that fasting will help us to achieve this. Going deeper into the pathophysiology, you see here 80 years of development of diabetes. The lady I showed you is about here, being very insulin sensitive. The father is about here. And I forgot to say is the difference between father and daughter is the father is very insulin resistant. The father needs about 80% of the insulin to regulate blood sugar. The daughter maybe only 2% or 1% of the insulin. So this is the position of the daughter, here the father, and this represents already the differences between both of them. And before hyperglycemia starts, a long time before insulin levels raises, represented by the two pictures of father and daughter, proinsulin comes later, but all this is transmitted by visceral obesity. So basically the visceral fat accumulation and the release of free fatty acids out of the visceral fat, and they make people getting insulin resistance. But now it's getting actually worse. There's the hepatic fat coming on the game. And you see here in the clinical situation of the father, there's suddenly hepatic fat increasing, it's continuously going up. And today we know the visceral fat is making us sick, hepatic fat is making diabetes progressing very fast and is responsible for our mortality. And finally, there's another candidate, it's a glucagon. And you see, even before liver fat increases, we have a rise in glucagon. And glucagon is the forgotten stepbrother of insulin, the same as all. There are 3 Nobel Prizes given for the glucagon. And the cool function of glucagon is that it can initiate beta oxidation of fatty acids. So it can break down or can initiate the breakdown of fatty acids. And in this clinical, physiological, complex matter, we now have to think about what is the right strategy. But here diabetes starts, and here we diagnose diabetes. So we start acting here, where the pathophysiology of diabetes, I would say, is basically over and is represented by a decrease of insulin release due to destruction of beta cells. So we come very late and should think about, can we act in this clinical paradigm to make a difference for our patients? These two fat compartments are responsible for diabetes mellitus. Here are examples of the fat compartments. The visceral fat is irrelevant for increasing diabetes risk. The hepatic fat is irrelevant for the progression of diabetes risk. Here, the insulin signal transduction cascade, all the red substances come out of the visceral fat, because the visceral fat today is not fat anymore. It's an endocrine hormone and is releasing more than 800 known hormones out of the visceral fat. And they make us getting insulin resistance, depression, impotence, hypertension, metabolic syndrome, all this chronic disease aspect. And this is the common soil for nearly all chronic diseases, also diseases like psoriasis, inflammatory origin. And as more liver fat you have, you become a non-responder for physical activity. So now, looking at this, it's actually a disaster. If I would ask you, what is the best way to get the liver, or let's start with the visceral fat, to get the visceral fat away, the answer would be physical activity. But if someone also has hepatic fat, then he becomes a non-responder for physical activity. He's, for example, walking 10,000 steps and it works only as 2,000 steps. And this makes a vicious cycle. And yeah, due to the accumulation of both fat compartments, he is in a cycle where it's very difficult to come out to prevent or to improve diabetes mellitus. Let's now compare, and I apologize for the German slide, let's now compare insulin sensitivity or insulin resistance on the y-axis, and then compare people without liver fat, NAFLD is a synonym for liver fat, and people with liver fat, and separating non-obese and obese. And we see here, obese people without liver fat have a better insulin sensitivity than slim people, but with liver fat. And we all know those people. We have them in our practice. They are slim and they get a type 2 diabetes. And we actually say, we don't know why, because we think they don't have risk factors. But the answer is, in many, many cases, is the pure presence of hepatic fat. And this is actually a good information, because what we know today is, and again, I apologize for the German slide, that the studies from Taylor has shown, I would say, shown eye-opening results Because the concept from Taylor is increasing fat in the liver and the pancreas basically destroys beta cell function. But he assumed the opposite also works. If you reduce liver fat and pancreatic fat, you restore beta cell function. And this finally can lead to a remission of diabetes. And this, in my eyes, is one of the most important information we have in terms of prevention and improving diabetes care. Now the question is, how can we get the liver fat away? I mentioned the visceral fat we get away by physical activity, but how the fat in the liver? And the answer is fasting. If you fast for 2 weeks without eating any kilocalorie, if you fast for 2 weeks without eating any kilocalorie, drinking water, so we could call it water diet, you can be sure that you abolish the liver fat up to a content from 100 to 120 grams. It means for many of our patients, this would mean the liver is free of fat after the fasting. And this is the fastest gain of health we can generate for ourselves and our patients. But we have to understand our patients, because the question is, where is it coming from? And if I would be in front of you, I would ask whom of you likes to drink Coca-Cola and who likes to drink Diet Coke. And to those with the Diet Coke, I would say it's better to stop this. There are 380,000 patient years on this slide. And it shows you if you drink one soft drink per day over a year, what it does with your diabetes risk. If you drink water, it's not increasing diabetes risk. If you take industrialized prepared orange juice or soft drinks, 40% like a Coke, but the Diet Coke or Coke Zero makes 60% increase of diabetes risk. And this is strange, we could say. How can the Coke, where there is no sugar in, make more diabetes risk than the Coke with sugar? And the answer are the artificial sweeteners. If you consume a certain threshold of artificial sweeteners every day, you change your microbiome. So imagine you're physical active, you eat a lot of artificial sweetener, you change your microbiome. And we could say, well, why is this of a problem? And so there are other bacteria invading our gut. They help to digest. It's not painful, so we don't recognize this. But what they are doing, they produce metabolites, and these are saturated free fatty acids or saturated fatty acids, which we have very difficult to metabolize. And what happens? They are stored in the liver. And this storage in the liver finally makes you becoming a non-responder for physical activity. And this is not good, because our intention is to do something healthy. We consume artificial sweetener because it's sugar-free, and by this we are doing the situation worse and accumulate liver fat. And this is becoming more and more common in the last decade because of the common use of products with artificial sweetener. There are 38 artificial sweeteners available. 36 do the change of the microbiome. Erythrit and stevia are two where it's shown that it's not so harmful and that they are not influencing the microbiome. And this is, for me, a clear answer for fasting. And from my side, a clear yes, that we should use fasting for our patients with type 2 diabetes, for diabetes prevention. But in my eyes, the clear power of fasting is to abolish the liver fat. There are many, many different ways of fasting, and I would say all of them are good. But if you really want to abolish the liver fat, it means 2 weeks, 0 kilocalorie, so basically a water diet. You lose a lot of body weight. There are two fasting periods shown with a body weight reduction of 10 to 12 kilogram over the 2 weeks. And my argument for the fasting would be like this. It's a very short, summarized way how to do the fasting, which I hope could become part of our guideline. Why is it so important? And I already mentioned this. It's the amount of fat in the liver. And here you see an MR spectroscopy picture before fasting and after fasting. And I think, and I jump back before fasting. after fasting. And I think it does not need more arguments and to show what is the clear physiological advantage of fasting. So what we know is eating less is healthy. It's good for your health. I would um, be uh, fast forward saying not to eat is even more healthy. It's the fastest gain of health. It's a challenge, but it's a very, very, very good achievement for the body. You lose weight, but the main thing is you abolish the liver fat and visceral fat, and you have a reset of the microbiome. And it's a very exciting personal experience. Here is shown an AGP of people 2 months after fasting. And can you remember the glucose curve I showed in the beginning from the lady? You see in this AGP basically a similar curve, a flat glucose curve representing a very good insulin sensitivity achieved by fasting. Two pictures of people who are fasting. There are 29 and 25 pictures, people on this slide, and the red dots are the glucose, and the blue line is the ketone bodies, because the power of fasting is generated by the body flipping after about 3 days from burning glucose to burning ketone bodies, and it needs to break down the ketone bodies or to generate ketone bodies by breaking down fat, and then to burn the ketone bodies for energy consumption. And you see how after the first day of fasting, the green line, the ketone bodies go up, and at this level about, the ketone bodies are very effective in breaking down fat to ketone bodies to get energy from it. And the interesting point is the first fat which is broken down, it's the liver fat. And the answer why is because glucagon is present in the liver and in the pancreas and has the ability to very fast switch on the beta oxidation of fatty acids. Here's a picture shown from obese people doing the fasting, and you see it's going faster up with the ketone bodies. Now, it's very early data, it's not published yet, but it may show that as more obese you are, as more effective the fasting could be. But it's a very early hypothetical statement in the moment. Summarizing this, I think to address the dysglycemic continuum by fasting will reach this effects, and we basically tackle the roots of diabetes, of the physiological diabetes development. And I must say, this is very important tool information for effective prevention and care of diabetes. Again, the statement how fasting could look like. Let's look at our guidelines, where I would position fasting before the start of medical or pharmacotherapy. If you look into our other guidelines, again, before starting in pharmacotherapy, I would add the fasting as a step. So imagine someone comes with newly diagnosed type 2 diabetes. I would recommend he should fast for 2 weeks without taking any kilocalorie. And then after 3 months of fasting, we should consider whether this is necessary to treat him or not. And the patient should be in the middle in this cycle with his needs. And again, here, I would position the fasting on this position. So remember, fasting is the fastest gain of health we can generate. It's worth to do this because it can lead, I would say, to 50 to 60% of our type 2 diabetics in the first 10 years of the disease history to a remission of diabetes, and it's a very effective strategy for prevention. I will become the next president of the International Diabetes Federation, and I will focus on prevention, prevention, prevention on all levels we can achieve, and will use digitalization as a tool to improve care and prevention of people with diabetes. And fasting under the roof of IDF could be a strategy to achieve this. And under my presidency, together with Akhtar Hussein, the current president, we initiate a group of discussing fasting and diabetes in all its facets, based on the very good work of the DAR Alliance currently done. Addressing the need of our patients is what we have to do, what we have to achieve. Why IDF? Because I think this is a powerful voice for people with diabetes, and it can change the quality of diabetes care. It can change the practice of diabetes care worldwide. And my vision is that we have to address the true need and right of every person in the world who has the right to get the appropriate measures for prevention and care. And our mission as IDF is to realize this, to provide or to enable an environment for every person with diabetes worldwide for the same access, affordability, and availability of diabetes care and its prevention. So there are many faces of diabetes worldwide. Our activities should put a smile on these faces because I truly believe that people with diabetes deserve a better life. Finally, is this enough? No, it is not. Walking 10,000 steps a day is the right strategy for prevention. Using a pedometer changes your daily physical activity. Looking at the pedometer count every 3 times a day makes you walking 3,000 steps at the end of the month more than at the beginning of the month. But don't trust a physician. 31 diabetologists on this slide in Germany, and 30 of them use the escalator. 1 is using the stairs. Airport in Doha, airport in Munich, and airport in Dammam in Saudi Arabia at diabetes meeting. This is us. We are not always a good example for people if we talk about physical activity. Maybe we can think about changing this ourselves. Don't forget the 10,000. Don't forget the fasting. Clear yes for fasting as a pure medical, non-religious purpose. And let's discuss this and work together and use all our intuition and ideas to finally help our patients to walk away from diabetes. Shukran, shukriya. Thank you very much for your attention.